This presentation reviews Limbrick and colleagues' 2017 PLOS-1 study on cerebrospinal fluid biomarkers in infantile congenital hydrocephalus. The central idea is that in hydrocephalus, ventricular size tells us about anatomy, while cerebrospinal fluid may tell us about active biology. The study asks whether proteins in the fluid can reveal neural injury, altered development, or disease mechanisms, especially in infants where the developing brain may be most vulnerable and where the biomarker signal appears strongest. Why look for biomarkers in congenital hydrocephalus? Clinically, we often describe the condition using imaging, symptoms, and ventricular measurements. Those are essential, but they do not fully describe the molecular state of the paraventricular brain. Congenital hydrocephalus is also heterogeneous. Some children have aqueductal obstruction, some have a patent aqueduct, and others have developmental malformations or genetic syndromes. A cerebrospinal fluid biomarker panel could help connect structure to biology by showing whether ventricular enlargement is accompanied by axonal stress, altered protein processing, inflammation, or impaired maturation. The study question was whether selected proteins in cerebrospinal fluid could discriminate untreated congenital hydrocephalus from age-matched controls, and also point toward underlying pathophysiology. The authors tested a biologically chosen panel. The amyloid precursor protein pathway included amyloid precursor protein itself, soluble amyloid precursor protein alpha, soluble amyloid precursor protein beta, and amyloid beta 42. Axonal and developmental markers included tau, phosphorylated tau, L1-CAM, and NCAM1. The panel also included aquaporin 4 and total protein as glial water and broad protein load signals. The cohort included 20 children with untreated non-hemorrhagic congenital hydrocephalus recruited between 2010 and 2014. Entry required ventriculomegaly with a frontal-occipital horn ratio of at least 0.4, plus clinical signs or symptoms supporting hydrocephalus. Importantly, cerebrospinal fluid was collected at the initial neurosurgical treatment, before prior hydrocephalus surgery could confound the sample. The authors excluded prior treatment, central nervous system infection, neoplasm, open spina bifida, hydranencephaly, and post-hemorrhagic hydrocephalus of prematurity. So this is aimed at untreated congenital hydrocephalus, not shunt failure or infection physiology. The hydrocephalus samples were ventricular cerebrospinal fluid collected during treatment. Controls and other neurological disease comparators were lumbar cerebrospinal fluid samples. Samples were transported on ice, centrifuged, aliquoted, stored at -80 degrees Celsius, and then tested by duplicate ELIS assays. The authors reported absolute biomarker values and values normalized to total protein. That normalization is important as it helps separate a specific pathway signal from a nonspecific increase in overall cerebrospinal fluid protein. The ventricular versus lumbar sampling difference remains a key caveat. The congenital hydrocephalus cohort was clinically mixed. 15 of the 20 children had aqueductal stenosis on MRI, and 5 had a patent aqueduct. 7 had developmental brain malformations. Among 10 children who had chromosomal microarray or targeted genetic testing, 3 had identifiable genetic alterations. Associated craniofacial, cardiopulmonary, and genitourinary anomalies were also described. Most children received ventriculoperitoneal shunts, with 1 endoscopic third ventriculostomy and 1 ventriculosubgalal shunt. The heterogeneity is a strength for finding a shared signal, but it also limits claims about any single cause. Total cerebrospinal fluid protein correlated with ventricular size, measured by frontal-occipital horn ratio, in both congenital hydrocephalus and control subjects. But mean total protein did not distinguish congenital hydrocephalus from controls. Children with other neurological diseases had much higher total protein, reinforcing that total protein is a nonspecific marker. In the diagnostic analysis, total protein performed weakly, with an area under the curve around 0.61. So ventricular size and global protein are related, but total protein alone is not a congenital hydrocephalus biomarker. In contrast, several candidate pathway proteins were elevated in untreated congenital hydrocephalus. The increased proteins included amyloid precursor protein, soluble amyloid precursor protein alpha, soluble amyloid precursor protein beta, amyloid beta 42, tau, phosphorylated tau, L1-CAM, and NCAM1. Aquaporin 4 and total protein did not show the same congenital hydrocephalus-specific elevation. This pattern indicates it is not just a broad protein leak. It suggests pathway-specific changes linked to neural injury, altered amyloid precursor protein processing, axonal stress, and neurodevelopmental cell adhesion biology. The amyloid precursor protein pathway showed its clearest separation in infants 12 months old or younger. In that subgroup, soluble amyloid precursor protein alpha and soluble amyloid precursor protein beta outperformed parent amyloid precursor protein and amyloid beta 42 as diagnostic candidates. The signal was less consistent in older children, which supports an age-specific interpretation. A single universal threshold may not be appropriate across childhood because cerebrospinal fluid composition changes with maturation. The practical importance is that infantile congenital hydrocephalus may have a distinct molecular window, where injury and developmental signaling are especially detectable. The cell adhesion and axonal markers support the same biological story. Tau and phosphorylated tau are compatible with axonal injury or altered neuronal integrity. L1-CAM and N-CAM1 point toward neurodevelopmental cell adhesion pathways, which are highly relevant in the infant brain. After normalization to total protein, N-CAM1 was less robust than L1-CAM and the tau-related markers. Aquaporin 4 did not emerge as a useful discriminator in this cohort. So the biomarkers suggest the tissue processes that hydrocephalus may disturb. The logistic regression models in infants are where the diagnostic signal becomes most striking. Normalized soluble amyloid precursor protein alpha was the strongest overall discriminator. Soluble amyloid precursor protein beta, tau amyloid precursor protein, and L1-CAM also performed well. The curves suggest that once marker values cross internally derived cut points, the modeled probability of congenital hydrocephalus becomes high. But the caution is just as important as the finding. These cut points were derived inside a small cohort, so they should be treated as hypothesis-generating, not as ready-made clinical diagnostic thresholds. The receiver operating characteristic analysis makes soluble amyloid precursor protein alpha the standout candidate. In infants, normalized soluble amyloid precursor protein alpha had the highest area under the curve around 0, 99 with sensitivity of 0, 94 specificity of 0, 97 followed by soluble amyloid precursor protein beta, tau and L1-CAM was also strong around 0, 89. Total protein lagged far behind. These are impressive internal results, but they need external validation before they can guide clinical decisions. Mechanistically, the study reframes congenital hydrocephalus as more than enlarged ventricles. Ventricular expansion may produce mechanical stretch, altered cerebrospinal fluid flow, ischemia, inflammation, and disturbed maturation near the ependyma and paraventricular white matter. The resulting fluid signature includes amyloid precursor protein pathway proteins, tau markers, and cell adhesion molecules. That pattern suggests tissue injury and altered protein processing, but it does not prove causality or identify the exact source of each protein. The useful conceptual shift is that cerebrospinal fluid can be read as a biological report from the developing brain. The study sampled untreated congenital hydrocephalus before shunt infection, revision physiology, or prior surgery could dominate the signal. It used a coherent candidate panel rooted in prior hydrocephalus and neurodevelopment literature. It also reported cut points, sensitivity, specificity, and area under the curve performance, not only p-values. The limitations are equally important. The hydrocephalus cohort was small. The infant subgroup was smaller, ventricular and lumbar samples were compared across groups, and there was no external validation. Bottom line, strong signal, high plausibility, but not a standalone clinical test. The implications point toward the need for further studies. First, the soluble amyloid precursor protein alpha, soluble amyloid precursor protein beta, tau, and L1-CAM cut points need testing in larger multicenter infant cohorts. Second, longitudinal sampling before and after shunting or endoscopic third ventriculostomy could test whether these markers respond to treatment. Third, biomarker levels should be linked to neurodevelopmental outcomes and imaging trajectories. Fourth, combined models could integrate frontal-occipital horn ratio, etiology, MRI tissue markers, and cerebrospinal fluid proteins. Near-term value is likely adjunctive phenotyping, not replacement of imaging or clinical judgment. Here are the take-home messages. Untreated congenital hydrocephalus has a distinct cerebrospinal fluid protein signature, especially in infants. Soluble amyloid precursor protein alpha was the standout diagnostic candidate in children 12 months old or younger. The amyloid precursor protein pathway tau and L1 CAM findings support a paraventricular injury biology rather than a purely structural diagnosis. Total protein relates to ventricular size, but is not a useful congenital hydrocephalus biomarker. Most importantly, these findings are promising, but require external validation and outcome correlation. Hydrocephalus cerebrospinal fluid may be a molecular window into the developing brain.